Good evening. I am Professor Lisa Burke from the Department of Rural Health at the University of Melbourne. I would like to begin by acknowledging the traditional owners of the lands from which this webinar is recorded from and streamed to. Myself, I'm here on beautiful Yorta Yorta country on the banks of Gailia, also known as Goulburn River, and I know others of you come to this webinar from various other traditional nations. So I pay my respects to their elders, past and present, on all these lands, and to any Aboriginal and Torres Strait Islander people joining us this evening. I acknowledge that these lands were never ceded and that they are home to the oldest living cultures on the planet. The University of Melbourne Department of Rural Health are very excited to bring you a webinar this evening with a panel of experts to discuss what to expect as we adjust to living with COVID. Just before I introduce our panel, it's suggested that viewers put their screen to gallery view using the icon at the top right-hand corner. We've had a lot of questions come in. We'll attempt to get through these. You can ask further questions through the Q&A and we'll see what we get through tonight. But we should cover a fair range of topics. But I'm very excited this evening to introduce members of our panel. To begin, Laureate Professor Peter Doherty. Peter is a graduate of the University of Queensland School of Veterinary Science. Peter received the 1996 Nobel Medicine Prize for his immunology research, and in 1997 was awarded Australian of the Year. Since then, he's gone into bat for evidence-based reality relating to areas as diverse as childhood vaccination, global hunger, and anthropogenic climate change. We also have with us this evening Professor Sharon Lewin. Sharon is the inaugural director of the Peter Doherty Institute for Infection and Immunity, which is a joint venture between the University of Melbourne and Royal Melbourne Hospital. Scientists from the Doherty Institute were the first to isolate and share the SARS-CoV-2 virus outside of China and have a broad program of research focusing on testing, treatments, and vaccines. And joining us shortly will be Professor Tony Blakely, and perhaps I'll introduce him when he joins us. But thank you very much, Peter and Sharon, for coming along this evening. And perhaps I'll just begin with a more general question. Can you perhaps tell us about the vaccines that we have here in Australia, how they work, how long they last, and their efficacy levels?
Sharon, do you want me to do that or you handle it?
I'm okay. I'm happy to start.
Good.
So we have at the moment the Pfizer mRNA vaccine and an AstraZeneca vaccine, and hopefully we will have Novavax, which is a protein vaccine. So we will have 3 different vaccines available in Australia. Very, very briefly, the Pfizer vaccine is a totally new type of vaccine. It's mRNA, which means that it's the genetic code of the virus that gets directly injected into muscle, and that message tells muscle to make the SARS-CoV-2 protein, and then your body reacts to it, making antibodies, which we know are effective in preventing becoming infected with the virus. The AstraZeneca vaccine is what we call a live vector vaccine. It is comes from the cold virus that infects chimpanzee, or chimpanzee adenovirus, and it contains a little piece of DNA and other genetic material that provides the code to also produce part of the COVID virus, which is the spike protein, which you make antibodies to, and it protects you against infection. And the Novavax vaccine, which we don't yet have in Australia, is more of a conventional vaccine, just like your hepatitis B vaccine, which is a protein with what we call an adjuvant, which gives a kick to the immune system to make a really good response to the protein itself. But again, it's the same protein. All of these vaccines are designed to attack proteins that sit on the outside of the COVID-19 virus. And what we've pretty much learned from the trials is that it's not too hard to make a good vaccine against COVID-19. I've spent my life working in HIV, where it's extraordinarily difficult. We do have no vaccine to protect you against HIV. But with COVID-19, all of these vaccines have done very well. And many people talk about this league table of how the vaccines perform, but I think about it slightly differently. I think about how the vaccines prevent against severe disease and then how they prevent against infection. And severe disease is really important because that is basically what we worry about, people going to hospital and potentially dying. And so all of the vaccines do very well on severe disease. They basically are not 95% effective. And we know that in the clinical trials as well as in the real world, in the UK, in Israel, in the US, we're getting reports of how these vaccines work in the real world. The other way that the vaccines are ranked is how good they are at preventing infection, and that's commonly called symptomatic COVID, meaning that you've got a positive test in your nose and you've also got symptoms, mild, moderate, or severe. And when you rank the vaccines like that, the Pfizer vaccine is probably the best, protects 95%. AstraZeneca, the numbers vary depending on the timing between the doses, but if you have 12 weeks between the doses, it can be as good as 80% protective. And the Novavax vaccine is probably up there with Pfizer, up around 90% protective. Novavax vaccine is one of the few vaccines that's also been tested in South Africa. It was developed, and in the UK, it was first evaluated, actually in Australia, the phase 1 studies were done right here in Brisbane and in Melbourne. And then the phase 2 and larger studies were done in the UK and in South Africa. And we know with that vaccine, it did really well in the UK, not as good in South Africa, where the protection against infection dropped down to around 50%. So that's how they work. The Australian government made a decision to back a range of vaccines of different platforms way back in July, before we really knew any of this data. And actually no one would have expected that the mRNA vaccines would do so well. They're totally new. And I, for one, who have been following this field, was just ecstatic when I saw how well they did. But no one really knew that back when we were purchasing vaccines. They're a little that we don't have the capabilities currently to make them, although we hopefully will have that soon in Victoria. But we do have the capabilities to make the AstraZeneca vaccine. And so the government wanted different platforms because we didn't know what the efficacy was going to be, and a capacity to make the vaccine here, which I think is very, very valuable. Because as you've seen, this great global competition at the moment for vaccines, and probably far greater need in many other countries than in Australia. We need a vaccine, but if vaccines stop you going to hospital, you really need them in places where you've got enormous amounts of infection and overrun healthcare systems. And then, so that was good. That was a very, I think, wise move. And now we have this very tricky situation, and it really is a tricky situation of a major and important side effect, but very rare side effect of AstraZeneca. So we've got some very good advisory groups in Australia that sit completely separate from government, a technical advisory group on immunisation called the TAGI, and a commercial advisory group. So this is not political decisions that are being made on how we use our vaccines. They're being made by technical advisors. And so those groups are very carefully weighing up this emerging data that we're seeing about an adverse event from AstraZeneca, which in our setting in Australia is very complex because we have no COVID here currently, but want to protect everyone from COVID. So the current recommendations is that the preferred vaccine for under 50s is Pfizer, because there's a suggestion that this adverse event from AstraZeneca is more common in the under 50s, but we're still getting data on that. And over 50 is Pfizer or AstraZeneca, but clearly much more likely to be giving AstraZeneca because there's limited availability of Pfizer. So that's just a very long introduction to the sort of background about vaccines.
Yeah, thanks, Sharon. And just before we go on, welcome, Tony. Thanks for joining us this evening. And
thank you. Apologies for lateness.
It's all right, and I'm sure most of our audience are familiar with you, but just in case, Professor Tony Blakely is Professor of Epidemiology at the Melbourne School of Population and Global Health at the University of Melbourne. And Tony's committed to answering questions about public health interventions and achieving the greatest health outcomes to reduce inequalities in health and to do so cost effectively. So thanks for joining us, Tony. Peter, did you have any comments at this point, or will I move on with some?
Well, Sharon gave a really
Yes,
thorough discourse on the vaccine. I think just to reinforce a couple of points, they're all against the same thing, the spike protein of the coronavirus, which is the one that binds to a cell surface protein called ACE2 and gets the virus into the cell. Viruses are obligate intracellular parasites. They have to grow within our cells. So they all cause manufacture antibodies against that spike protein. So potentially, for instance, we could mix and match vaccines. And there are some trials going on to make sure that's completely safe. There's just different delivery mechanisms. The options available to the Australian government re-vaccines were very limited in a sense, though they signed on for a number of possibilities. And we can make protein-based vaccines here. That includes the AstraZeneca and the Novavax. And now, of course, we've got this great announcement from the Victorian government that they will put $50 million towards making these mRNA vaccines, which have been absolutely wonderful. And like Sharon, I was just blown away when we saw the first results of these vaccination trials, because all of us were thinking this would work about as well as influenza vaccines. There are a lot of complexities there, but they work a lot better than our influenza vaccines. And it's been very encouraging. And the only issue is this problem with the side effect with AstraZeneca, particularly in younger women. It's probably around 1 in 100,000, maybe less, but it is a concerning issue.
Yeah. Okay. Well, we've actually had some questions about, comparing the current vaccines to the flu vaccine. Can any of you comment about perhaps the differences? And
yes, I've just written a whole series on that for our website. The flu vaccines are. A flu vaccine is a vaccine actually against 4 different viruses, all of which, the ones that we get in Australia, are all grown up pretty much either in tissue cultures or in eggs. And then the virus is cleaned up and in various ways, and it's killed, so it's not infectious. So it's a fairly old type vaccine, in fact, and we give a more powerful one with a lot more stuff in it to older people, because older people don't respond as well. So you've got 4 different viruses with a virus that actually changes very, very fast. We know that the SARS-CoV-2 virus that causes COVID can mutate, and it is changing and mutating, but it doesn't do that fast like Sharon's virus, the AIDS virus, does, or like influenza does. And sometimes when you vaccinate against influenza, you have to decide, there's a committee in Geneva that decides. Two of the members of that committee will be Ian Barr and Kanta Subbarao from our institute, who run the World Health Organization Influenza Center here. They decide 6 months ahead which vaccine should be made. So then they pass that on to the manufacturers who make the vaccines. Now, the problem can be, especially with 4 different viruses, then one of those viruses may change substantially. So sometimes you get a flu vaccine out there that's preventing 30% or only 30% effective with one of the flus, 70% with another. But they never get up to the 80, 90% levels that we've been seeing with COVID-19. And I think part of that may be that influenza in us is a disease that's restricted to the respiratory tract. It's the upper respiratory tract and the lung. COVID-19, on the other hand, the virus gets into the blood as well. It also has that respiratory problem, but it also gets into the blood and gets around the body in the blood. And I think personally, and it's a speculation, that's why these vaccines are working so well, because they stop that blood phase.
Okay, thank you. You also mentioned the new funding. I was just wondering if you or Sharon would like to talk about the announcement of the new funding and what that will achieve in the next few years.
Yeah, well, many people have been asking for many months now, why can't we make mRNA vaccines in Australia? And it is new technology, and it will not require new infrastructure and new expertise. So to make RNA vaccines in Australia will require many, many more $1 million than $50 million. But what the investment is from Victoria is to bring that technology here to make vaccines at a grade that we can at least test them in animals, make sure that our research communities are taking advantage of this new wave of technology, because mRNA will have a lot of implications for other vaccine development, influenza, HIV, dengue, all these many infectious diseases that have been very difficult to make vaccines for. So I don't see this announcement as that's going to mean more Pfizer this year. I see this announcement meaning that we will have access to this new technology that will change how we develop vaccines for our research community to eventually commercialize and deliver vaccines for the future, I think. I'm not sure that $50 million alone is going to create what's needed. If, say, we were to make Pfizer here, we would need sort of a technology transfer. And I don't think this level of investment can do that, but it means that we can get on to and be part of this sort of revolution in vaccinology.
Yeah.
Yes, it'll take a while to get off the ground, and it'll need a lot more than $50 million. And there's a lot of steps in it that to actually make a vaccine, and especially, say, if you had to make a new facility, apart from buying the equipment, getting the materials made that go into making it. They have to, all this has to be in certified space under what's called GMP practices. And then at the other end, you've got to be able to put it in bottles and get it out there. That can be a big problem. And Singapore, for instance, is specialized in just putting stuff in bottles and shipping it out. So there's a lot of steps, and it's much more complex than we think about in the simplistic terms. You can do that pilot study in a sort of an academic type of way, but really getting it out there as a commercial enterprise, unless someone like CSL takes it up, which has great stature in this area, not with these vaccines, but with protein vaccines. It will take a while, but this is going to continue for a while. We're not going to be over this so fast.
Yeah, but it sounds like it's a step in the right direction in terms of these new types of vaccines to be moving into the mRNA. Yeah. Given that Australia is focusing on AstraZeneca and Pfizer, are there any other options that Australia could be considering? And just with that, I've had a question here about the UQ clamp vaccine and why that was aborted by the federal government.
Yeah, so they are considering more than Pfizer and AstraZeneca, and that's Novavax. Novavax, I mentioned earlier, is a protein vaccine, so we're very comfortable and used to protein vaccines. It has a unique adjuvant. Adjuvants are there to boost and stimulate the immune system so you make a good response to the protein. But Novavax are a company that haven't made vaccines at a large scale before, and so the actual timing of when Novavax is not yet approved, so any new vaccine goes through a complete technical review and approval by the Therapeutic Goods Administration, and it hasn't yet been completed for Novavax, but I understand it's underway, and delivery of the Novavax vaccine may well be later in the year, and I gather it's not clear exactly when delivery will occur. The UQ vaccine, well, we were all very disappointed the UQ vaccine didn't work. Many of our staff at the Doherty Institute were collaborating with the University of Queensland. We would have loved a homegrown vaccine. And the UQ vaccine was actually a clever vaccine. It was a protein vaccine, but it also had spike protein, the same as all the other vaccines. But the spike protein kind of wobbles, it's got 3 parts and it wobbles around a bit. And to get the best immune response, you need to fix it in place so that your body sees the right part of the virus to make an antibody response. When it wobbles around, you don't get a very good immune response. And so the Pfizer vaccine, for example, has a way of stabilizing the spike protein with a mutation in the protein. What UQ did was it clamped it at the bottom with a piece of the HIV virus that works as a clamp. Very clever technology. In fact, they were funded as a platform, meaning a great strategy to rapidly switch to a new virus. And they were funded to develop this platform with the HIV clamp. Now, what they thought would be possible, but were, I guess, hoping it wasn't going to happen, was that when you inject the whole thing, the stabilized spike and the HIV clamp, you make a really good antibody to the spike, which means it's a good vaccine, but you also make an antibody to the HIV piece. And they found that everyone made an antibody to the piece of HIV. That does not mean they have HIV, does not mean they're infected. It means that if they had a blood test for HIV, it lights up positive. Not every test, but about 90% of the tests available would light up as positive. And that just brings an added complication. Just say we vaccinate our whole Australian community with a vaccine that makes your HIV antibody test positive. It becomes a real issue in diagnosing HIV. It becomes a real issue in screening our blood supply. It becomes an issue in some situations with travel. People said this is all because there was stigma against HIV. I don't think it's stigma. I think it would actually have complicated our whole public health program for how we manage HIV. Now, if there had been no other vaccines, we could have got around it. There were actually ways to get around it, but we were having vaccines that had 95% efficacy and none of these issues. And so the tough decision was made to pull out a very large amount of money, which, but the University of Queensland back working and developing other ways to do this.
Yeah, it could have been quite easy to develop an antibody test that would have differentiated between that vaccination and infection, but it was CSL who was going to make it. CSL is the world's biggest blood products company. They're giving blood and plasma to people all the time. So basically the last thing they want is something that reads as HIV positive. And it probably wouldn't be possible to use that in all sorts of situations because of regulations in various nation states. So unfortunately, it fell down on that issue. And there are also other protein type vaccines, including 2 that are under development in the Institute, but they're at a much, much earlier stage. And that's the problem, the time that it takes to get through those regulatory and trials and then the approval processes.
Yeah. And there's a question here about Moderna. Is that an option or?
Moderna is almost identical to Pfizer. It is also an mRNA vaccine, but exactly the same piece of the virus, but it's packaged in a slightly different. In the RNA vaccines, the genetic material is packaged in a fat bubble, and it's slightly different packaging, so it makes it a little bit more stable. But now, we originally had to keep Pfizer at ultra cold temperatures. It's now possible to keep the vaccine at higher temperatures. Very similar results in clinical trials. Moderna was developed as a real US success story. The research comes out of the major research institute in the US, the National Institutes of Health. They partner with the American company Moderna. It was fully funded by the US. And so the US government had an agreement that most of the Moderna would go to the US. And very few other countries have bought and are now using Moderna. I think it's just the UK and Canada. And we have not been able to secure access to Moderna, but it actually is much the same as Pfizer.
Okay. All right. And what might you say to Australians that perhaps are a bit unsure about getting vaccinated? Like we have a lot of Australians who are really keen, ready to go. We have a proportion who, aren't interested in a vaccine. But I think there's actually a large proportion of Australians who are a bit undecided, who are a bit wait and see, a bit unsure. What would you say to them about getting vaccinated?
Peter, do you want to take that?
Who wants to take medical advice from a vet?
All right. Well,
I think this is one for you, Sharon.
Yeah, I would say it's entirely normal to feel unsure. This is a new vaccine. It's come out quickly. We're reading all different things about it, and we're also hearing different rules about who should get the vaccine. So it's really understandable. But I think people should be reassured that the vaccine came out quickly, not because corners were cut. It came out quickly because the world galvanized around this and invested enormous amounts of money, so that instead of waiting for each phase of development, we normally go through 3 phases of development sequentially. Phase 1, does it look good or not? Get money, invest. Phase 2, does it look good or not? Get money, invest. Phase 3, which can often take 5 to 10 years. It was all overlapped. So basically there was a lot of investment with the idea that we're investing all this money to go on to phase 2 before we know the results of phase 1, because we need a vaccine quickly. So no corners were cut. The same process was used. It was just overlapping. And I think also now, Australia, we've been in a position with starting our vaccine program later than other countries. I've lost track of how many people, when I last looked, I think it's probably would be about 800 million or something like that people have been vaccinated, extraordinary numbers. So we really do have a good understanding of safety of the vaccines. And although we're all, I'm very keen to learn more about the adverse event from AstraZeneca, it is still very, very rare. We need to learn more about it, and we'll use it in the safest way. But the Pfizer vaccine, there are a few side effects for sure. They'll be explained to you when you go to your doctor. Having a vaccine, though, really helps you, depending on what your age is, particularly if you're elderly, it will help stop you from dying should you get COVID. It is that good. And if you're younger, where you think, well, I can't really get that sick with COVID, it will protect other people. The more people we get vaccinated, the less virus that will be circulating in the community. It's also important for people to know that there is I'm sure people may well know that about 30% of people can get long-term symptoms from COVID, something we call long COVID fatigue or respiratory functions impaired, unclear thinking, non-specific symptoms, but I think they're very real. And so even if you're young, so I think there's benefit for yourself and benefit for the community. There's lots of information out there. It's really important that if you're hesitant to look at trusted sources of information. And for me, that comes from the Australian government and the Victorian government, because you can read a lot of random stuff on other sites that are not they're not substantiated at all. Speak to people that have been vaccinated, speak to your GP, speak to community leaders. I think all of that helps reassure people.
Yeah, thanks. So you mentioned, long COVID. There's a question here about long-term impacts from the vaccine. Is there any evidence to suggest that there are long-term impacts?
No, not at the moment, but then we haven't had the vaccines for long. So the first studies were done phase 1 studies were done as early as March and April. And then the first big studies were done in July. So there's recently been some reports of the Moderna vaccine 12 months later, no long-term side effects and pretty good immunity. So many of the vaccines we have only followed up for about 6 months. Few of them have gone out to 12 months. Long-term complications from vaccines are really rare. I mean, if we see an adverse event, it's usually immediately or within the first month of receiving the vaccine. Seeing things years down the track is very rare. I don't know, Peter, can you think of an example of seeing a vaccine adverse event many years?
No, not really. I think with adverse events with vaccines, you'll usually see them emerging within the first month or so. You can see, for instance, a condition called Guillain-Barré with influenza virus, which is a neurological condition that leaves people in bad shape for a fair while, usually irrecoverable, I think. But the incidence of Guillain-Barré with the vaccine is, I think, less than 10% of the incidence of Guillain-Barré if you get infected with the virus. Okay, so it is mimicking what happens with the virus, but at a much lower frequency. After that 1819 influenza pandemic that was so terrible, there were a number of chronic sequelae of that infection. Of course, there were no vaccines. We didn't even isolate that virus until any influenza virus till 1933. So you can see how the technology's changed with COVID-19. The first case reports are back in December. We have the virus isolated immediately. We have the gene sequence up online on July the 15th. People are starting to make vaccine within a month. The basics for the vaccine and the tests within a month of the disease actually being detected. And in fact, Mike Catton and Julian Drews of our institute had a test within days of the sequence being announced, and that was used to diagnose the first case, which is really only, I think, about 9 or 10 days after the sequence is published. And so the speed is extraordinary. And the fact of the vaccines being out there is because of the speed and precision of the technology and the advances. We're way ahead of where we were, for instance, when the first SARS problem hit in 2002, 2003, way ahead. So the fact that we've had a vaccine out there quickly really reflects advance in technology. And the vaccines that went forward fast were the ones that could be advanced very quickly and made in large amounts. The Ebola, the AstraZeneca vaccine, the same technology is out there in the Ebola vaccine. And that's the only place that's been widely used. And of course, the mRNAs were completely new in humans. One thing about the AstraZeneca is a lot cheaper. I think it costs about $4 to make, and I think Pfizer's about $20 or something. It's there's a big price difference.
Yeah. Well, maybe just given that you mentioned the Spanish flu, Peter, we had a question here about how did we get rid of the Spanish flu if there was no vaccine?
Yes, what happened with the Spanish, well, the poor old Spaniards, you know, didn't start in Spain. It actually probably came from China to the United States to Spain in military troop ships from the United States. But both sides of the conflict, the Germans and the Allies, weren't admitting to have it. And so the Spaniards who weren't in the war said, hey, we've got the flu, so it's called the Spanish flu. So you never, the lawyers will tell you, never admit to anything. I mean, you know, you're stuck with it forever. And basically, General Ludendorff, the two German commanders were Hindenburg and Ludendorff. Ludendorff says basically the flu finished the war. It finished off the German initiative. They couldn't continue. And it had major implications. Also, if you ever saw that movie Awakenings that starred Robert Williams about all these people who were in comas and they were woken up for a time by giving a dose of L-Dopa, they were people who were suffering from a disease we all know called von Economos encephalitis lethargica. And that was a sequel of flu. So viruses can give you very bad sequelae. And as Sharon said, and as was mentioned, we have this long hauler problem in COVID, and it's much more prominent than we have with most infections. Older people, particularly, who get very sick with flu, may never really come back with it. And it could be that final phase for them. But with this long haul problem with COVID, it's not age distributed. It's right across all age groups. It may be as high as 10% of cases have it fairly dramatically, and 30% have some long-term sequelae, even people who have no initial symptoms. So we don't understand this very well. We understand what's happened if someone has had severe disease and has cardiac damage or lung damage. It's very severe. But what we're seeing is this long COVID emerging in people who may have had a very mild initial course. We don't understand this, and it will take time to work this out. And whether there will be permanent sequelae is, apart from the people who've had severe damage, is really not clear. And a lot of studies going on, big data sets.
Well, that brings me to another question that's been asked, and that's about our kids. Why hasn't the virus affected children to the same degree as adults? And what do you think about children and vaccination?
I can have a crack at that one.
Tony, would you like to answer that?
Yeah, sorry about the lateness.
So patiently going on and off Wi-Fi, but I think he's got stable connections now.
Yeah, I'm sorry about that, guys. My Wi-Fi dropped out. It's been stable all day. I won't talk about why the virus doesn't affect kids as much at the biological level, but I do think there's, in about 4 months' time, we're going to be talking about kids and vaccination a lot. Now, the reason is as follows. I speculate, but I'm pretty confident in this one. Once we get through the adults down to about here on the vaccination, let's say we've got 70% of them done, maybe even 80% of them done. We're not going to be able to just open up our borders and live normally, because as soon as the virus gets in, these kids, 25% of the population, they tend to hang out together. It's called schools. And even though they don't transmit as much, they'll transmit enough to get the virus circulating. It'll go back up into the adults and cause some serious illness amongst those who either didn't get vaccinated or for whom the vaccine didn't work as well. So vaccinating children is something that I know that Sharon hasn't talked about it much. I don't know if Peter has, but I'm not talking about too much at the moment. But when we get to about 4 months' time, when we're thinking about vaccinated children, it'll be a really important discussion, because the children individually stand to gain less from being vaccinated. That's the population that will benefit. And I'm not quite sure how that discussion is going to roll. I've been thinking about it a lot, and I think we're going to need to reframe it as we've got to open up anyway, because we can't live, you know, down here in the South Pacific like we are now forever. And I think the discussion will have to be about, if your child's not vaccinated and they get it naturally, whilst they're unlikely to get serious sequelae, it will be of a higher chance than if they're vaccinated. But that's going to be, to me, a very interesting moment. I don't think we'll get to the children this year. I think it'll be next year, but the discussion will start this year. There's my crystal ball gaze for the first comment I have.
Yeah, that's interesting. I agree with you, Tony. It will not be straightforward. Children are less susceptible to COVID. It might be related to, Peter said earlier that the COVID latches onto a receptor called ACE2 that's in the nose, and you've got the most ACE2 in your nose, and it decreases as you go down into your lungs. And children have lower density of that receptor, and that might mean why they are protected. They're very unlikely to get sick, and that might be related to their prior exposure to coronaviruses. Older people have a lot more prior exposure to other coronaviruses, and that seems to lead to some dysregulated response to COVID. So it's their immune response, it's how much receptor they've got in their nose. And we're only just learning about the safety of vaccines in children. The Pfizer vaccines are being reported for 12 to 15-year-olds, and it looks safe. It's immunogenic. They didn't need to do efficacy testing in children because that's already been done in adults. And I understand Israel is now rolling out that they've already almost finished their adult population. They're now vaccinating their 12 to 15-year-olds, but there's been no studies yet reported less than 12. And I think AstraZeneca put a hold on their studies for children at the moment.
Yeah, it's interesting. I'm different from flu, where the kids are often the people who bring it into the household. I mean, the epidemiological evidence, and Tony's will qualify to speak on that, is that really it's not usually kids who are bringing it into the household. But as he says, if you've got they're the only vulnerable people, they will be infected and likely to transmit. The other question I didn't answer is why flu died out. We don't actually know, but what tends to happen with flu is that a flu strain either gets replaced or it seems to go to lower virulence. And that's what seemed to happen after 1918-19. The virus, by the time it got to Australia, it was 1919. It wasn't quite as virulent as the initial situation in Europe. And then it seemed to just stick around for a while and just gradually diminish. So we're hoping that'll happen with SARS-CoV-2 and COVID-19, but so far there's no sign of it at all. And maybe when we get this wall of antibody, this herd immunity due to vaccination up, maybe we'll start to see that. We're hoping we will.
Yeah. And what about the rollout of vaccines in Australia? Some suggest it's been very slow, and other people say that Australia is taking a more cautious approach and seeking out high priority groups first. What are your thoughts about it, and what do you see happening in the next 6 months in terms of vaccine rollout?
I'll have a crack at that one as well. I think it's been a political shindig in the last 3 weeks. So we've actually done really well where we've got to as a country, and we've had some hiccups, and there have been problems between that state and federal level. But we're doing about right on the trajectory of countries from the day they started the vaccination. We're not doing as well as the UK and the US, but they had an emergency situation. So I do think there's been a lot of politics here, with politicians seeing that they've suddenly got an inroad to attack, and there's been hyperbole up. So I think we're doing okay. I do think we can and should speed it up, but not to the point where we speed it up so badly that people get lost on the age register, that we can't trace people up. There's a certain speed at which we can do this. And we now know that we're not going to be able to do less than 50-year-olds until the last quarter of the year, when there's a lot more Pfizer around. So the trick now is to get through to about October and get the 50-plus-year-olds vaccinated with AstraZeneca, and that is achievable. Whether or not we'll achieve the sprint of getting everybody less than 50 vaccinated in those months from October to Christmas is moot, maybe, if we've got really good systems in place, but maybe it will take till January or February, and that's not the end of the world in my view. What is more problematic is how do we open up our borders, and we might talk about that a little bit later, but I'll stop there.
Yeah. And so we're likely to require boosters after we get through vaccination?
We don't know yet.
Okay.
The head of Pfizer came out recently saying we will almost certainly need a yearly booster. I'm not really sure where that comes from, to be honest, because the data that there's been no studies yet. The data from Moderna a year later, the antibody levels looked good, and you can actually get a drop of antibody levels. That's normal when you have an infection, a good antibody response. Your antibodies drop. When you see that infection a second time, your antibodies go right up again because you've got memory for that infectious disease. So just even if we saw a decline in antibodies, that doesn't necessarily mean that you're susceptible again. So we haven't seen people go out long enough. The real issue, though, is these variants of concern, and whether they're able, these strains that you would have heard about that were first described in the UK and then described in South Africa and Brazil and India, in New York City, and you know, can new strains infect you even though you've been immunized with a vaccine that recognizes an old strain? And that's probably the bigger concern. And that's really what we deal with flu every year. The flu virus changes a lot more than COVID, but it changes, and that's why we have to adapt the flu vaccine every year. It's not because your immunity falls off. So so I think there's a few unknowns. I would say for the next few years, I would predict, I'll use Tony's using crystal ball, I'll use a crystal ball. It's just pure speculation, even though you will hear people confidently saying we'll have yearly boosters. You know, I think most likely we will have a yearly booster while we're still seeing evolution of the virus. And a few unknowns there. We don't know how many times you can give an mRNA vaccine. One of the problems with the mRNA vaccine is it actually makes you feel unwell in about 25% of people after the first dose, sore arm, maybe fever, a bit of aches and pains, unlikely to take time off work. The second dose, 50% of people have those symptoms, and something like 10% of people take the day off. That's the data from Australia. With AstraZeneca, it's the reverse. You have more side effects of the first dose. So that's high. That's a lot higher side effects than you would have with flu. So if you give a third dose of mRNA, we don't know. And also a third dose of AstraZeneca may also not be feasible. So there's a few things to nut out, but that's when we might start mixing vaccines, as Peter said before. Maybe the booster dose could be a simple protein vaccine.
Yeah, that would make a lot of sense, really. I mean, with the AstraZeneca, you're also making antibodies against the adenovirus protein, which is surrounding, it's acting as a shell for the coronavirus material. So we're making antibodies against that, and we're already pushing it by doing it twice. And I think that's why waiting 12 weeks may work better, because that initial response to the adenovirus is falling off. But if you've got a lot of antibodies around there when you give a vaccine that will grab it immediately, you'll change the way it's handled in the body, and it may not give you a very good vaccinational boost. So I think we wouldn't be using AstraZeneca, for instance, a third time. You might, if we thought the adenoviruses are perfectly safe, and at the moment we do not, we might go to another one of those, but you could certainly boost people who've had AstraZeneca, I believe, with Pfizer or with Novavax or with anything else. But our regulatory people would want to see some data that that's safe and efficacious. But I don't think it needs to be the massive trials that we've done initially. And I think those trials are being done in the UK already, aren't they? Or they're certainly planned to be done very soon.
Yeah, the at the moment the UK are doing mixing studies.
Yes.
At first jab AstraZeneca, second jab Pfizer, and vice versa.
Yeah.
But the booster vaccines, or the third vaccine, I think are largely happening with the same vaccine. So for example, Moderna have developed a vaccine against the South African variant. They're giving that to people that were fully immunised before, and then giving them a booster shot with this time more highly active against the South African variant. So
yes, I think
those studies are happening now.
I think it's likely we can use the mRNA vaccines over and over, just as you can with a protein vaccine, if you can give variants of that. But I think the worry is, and we've discussed it, is the actual formulation, the material that it's packaged in. Can we give that over and over? But we don't know. We're in unknown territory. But this is something that can be worked out fairly quickly, I think.
Well, while you're all using your crystal balls, can I ask you about travel? We're all keen to travel again. When do you think we will be able to see the world again?
I'll have a crack at that one. Look, it's longer than what Joyce thinks as CEO of Qantas, unfortunately, because once people...
We are travelling. We've got to New Zealand. That's good enough.
Okay, we've got a travel bubble to New Zealand. I've got to get back and see my own family. Beyond our travel bubble, I think until we've got down to 50-year-olds vaccinated, we won't be relaxing at all. Even at that point, we're still a fairly susceptible population to the virus coming in. Yes, our elderly may be protected. Yes, our comorbid people will be protected, but 80% so. And if you've got everybody less than 50 there, the virus will just take off if it gets in. Now, as we come down to having all adults, I think then it's going to be a bit easier to open up. And I think opening up will be very incremental. And there's some things that are not being discussed at the moment. The first one is somebody coming from the UK, US, or Spain have got a much higher starting risk of having the virus unwittingly in the first place. Somebody in China, I worked it out, I was publishing the conversation on Monday, I forget, it was several zeros, 0.1% chance. Now, people talk about vaccinating people to travel. That is no panacea, but it's pretty good, because it will lower your chance of having the virus by 80 or 90%. And then if you are unlucky enough to have it, you'll be less likely to spread it because of that reduced load. I see no reason epidemiologically, I'm going to be contentious, I see no reason epidemiologically to not be bringing in East Asian country students next semester if they're vaccinated without quarantine. There'll be a risk there, but it's very, very low. That does not apply for people coming from the UK, because they're starting at a higher level of water flow, if you like, compared to this tiny trickle down here called China. So there'll be those types of decisions to make. Then we'll probably move on to things like, for some people, it'll be safer to do home quarantine because you're less likely to pick it up from the room across the corridor in the hotel. So home quarantine will come in, and we'll probably move to shorter quarantine, because 14 days gets 98, 99% if it's done properly, but a week might get 70 or 80%. So everything's going to be about reducing that risk. And if it was done epidemiologically correctly, I think we'll be looking at the country they're coming from and the virus load as the first instance. And I've already made that brave contention. We could be bringing in people from East Asia now if they're vaccinated. I think that's a blanket rule. Anybody coming in with no quarantine has to be vaccinated, but you only bring them in from countries with really low load to start with. And then we'll slowly inch forward from that. And we may have to backtrack a bit if we see a sudden outbreak. It's not going to be a risk-free enterprise. There's my view on it. And I'm sure Sharon's leaning forward. I think she wants to comment.
No, I like it. I've been sort of saying something quite similar, that we'll have a stratified quarantine system. At the moment, we've got one model suits everyone. Makes no sense.
It makes no sense.
China or coming from the UK. And definitely vaccination reduces your risk. There's a few issues around maybe the type of vaccine, because Sinovac, or the Chinese vaccine, we think is much less efficacious, but still the biggest thing is how much COVID's in your country. And if a country like China is having, I haven't looked recently, but maybe they're having 70 cases a day in a country of 2 billion.
Yeah, I looked yesterday, and I think from the numbers, there might be about 100 people, if you believe their data, there might be 100 people in the country at any one point in time who are infected and don't know it. Right. You divide 100 by 1.4 billion, you end up 0.00000 something percent.
Yeah. So I think that and I think we can look at varying models: home quarantine, etc. So we've got this, we've got a blanket rule at the moment, which we've needed, but we need to start stratifying that. Except even at the moment, most of the country has a no risk approach. So I fully see what Tony's saying, a low risk approach. It's still going to be a big shift.
Yeah. So I talked before. It's okay if I talk now, Sharon?
Yeah.
Just jumping in. So I talked before about the discussion about kids happening in about 4 or 5 months' time. The discussion in the next 2 to 3 months, I think, is going to be about when as a country do we pivot from being zero tolerance to tolerating a little bit, which I don't think we'll actually start to do towards the end of the year, but we're going to need to have that public discussion. And I had one journalist get stuck into me and says, Tony, you've created this elimination world and everybody wants no risk. It's your fault. But we will need to pivot from no risk, that zero thing, and start accepting at some point we'll accept that the virus is going to get in a little bit. And that's going to be an interesting thing for the population to pivot like that, but not pivot so rapidly that we let it in too early. So I think that's going to be an interesting risk communication, public exercise. We've got uncertainty in it, but that's the type of pivoting that we're going to see. But we don't need to pivot. We don't want to pivot until most adults are vaccinated, to be honest.
And I think the biggest challenge we have in a country like Australia is that every state has a different risk appetite. So we will have states that will still say, no COVID, Western Australia, stay locked down. So it's going to be a challenging discussion. And the other thing is that Australia will have to walk in step lock with New Zealand, because New Zealand's border is now our border and Australia's border is now New Zealand. So the country's going to have to work together if that bubble is going to keep moving forward together. Sorry, Peter.
No, the big unknown is, of course, what's happening with mutant viruses. And as was mentioned, fortunately, we're in the position of being behind everybody else. So if any of these mutants start to blow through on vaccinated people, and we get severe infections in vaccinated people, we'll know about it. And that probably will be well before we're trying to open up. But the other thing we really should have is some better form of therapy. And we do have monoclonal antibodies that could be used for treatment. They're very expensive, and I think they're running through approval processes in Australia now. But a lot of people in Australia have had monoclonal antibodies for all sorts of things, like rheumatoid arthritis treatment or cancer treatment or various other things. So there is some treatment there, but it would be very nice to have some very specific antiviral drugs. And that's been very slow to emerge for some reason. And I don't think any of us quite sure why that is. There may be some promising candidates coming on, but it's taken a long time. Yeah, and it's really interesting that monoclonal, these antibodies that are made from people that have a really good antibody response from COVID, you can pull out their sort of antibody manufacturing cells and grow them in the lab and make it into therapeutics. They work in prevention. So with some infectious diseases like hepatitis A, if someone's infected, we can give people the vaccine that surround them, or give them antibodies that surround them to protect them. So antibodies could be used as a way of ring fencing an infection in a population that's not yet immunized. So, with Tony's thing of no risk, low risk, if we have a bit more. Now, if we just had a simple tablet, even better. For HIV, you can actually just take an antiviral drug and it prevents you from becoming infected with HIV. If we had something like that for coronavirus, that would add to our vaccine strategies. And Peter's right, it's been very slow. It's probably not easy. That's probably why. Yeah. Could be. But, the thing about COVID-19 is we're testing in a way that nobody has ever done before in a virus infection. Never with influenza, never with anything. We're doing this extremely sensitive test that picks up small amounts of nucleic acid from the virus, and it can be actually a minimal infection. And so many of the people who test positive, big shock and horror, but they may have very, very low amounts of virus or even no live virus around at all. But if, on the other hand, say we were bringing someone in and they come in and they test positive, if you could give them just a tablet right at that stage, because it would be early, because they would have left wherever they were coming from without any evidence of infection. If you could do that, it would probably stop it. And so it's a bit disturbing. But I think one of the things we should do in the future, the types of drugs that Sharon was talking about for HIV, will work against all those HIV-type viruses. And the type of drugs we have for influenza, which work fine if you give them right at the beginning of the infection, work against all the influenza viruses. We could make drugs that work against all the coronaviruses, or all the viruses that are threats, really. And we should do that. That should be one of the things we do so that we don't have another catastrophe.
Well, I think we've learned from this one. What about a third wave? Do you think there's possibility of another wave? And how effective are, short-term snap lockdowns to address when it does creep up on us?
Yes, and effective. There you go, there's the answer. If the virus gets into the country, like Brisbane 3 weeks ago now, I think it was, if that virus had got in there and it had started to spread and the contact tracers had not been on top of it, and it was one of the more transmissible variants, we could have easily seen another wave. So yes, it's very possible that that could happen, particularly if people are becoming complacent about wearing masks, keeping distance, all that sort of thing. Are lockdowns effective? Absolutely they are. Do we want to keep using them? Only if we have to. But if we're going to open our borders up, if we really want to get our borders open up before we've got everybody offered the vaccine at least, if we're going to take that risk, society needs to understand that we may well have to do a few more lockdowns. They may not be as severe, the lockdown, because of the fact that there's partial herd immunity, to be sort of colloquial about it. So things won't spread as quickly. So to answer your question, could there be a third wave? Absolutely. Will there be? Well, it depends on how unlucky we are and what we do. There's a combination of luck and what we do. And do lockdowns work? Yes. Will we need them again? Possibly, but hopefully not as severe.
Okay, and just before we close, can I ask each of you, will we ever get back to a normal, or what might that future look like in the next year or two?
I'll start. I'm inherently a very optimistic person. So yes, we will get back to normal. I'm very confident we will get back to normal. Look at the incredible knowledge and science and interventions that we've developed in just 12 months. This is definitely a tricky virus, no doubt about that. And it requires not just science, it requires strong leadership, community buy-in, empowering vulnerable communities. There's all these social factors that you need to combat coronavirus, not just a vaccine. I think we've demonstrated that in Australia when you compare our response to the US or the UK. But I'm confident that we will, that eventually we will get back to normal. I hope that there will be many, many learnings from COVID-19 of how we fund from how we have our employment to how we live in cities to, the science that will spill into other areas. But it may take a few years, I think. I don't think it's going to be all over at the end of this year.
So to follow up from that, I would also agree that we'll get back to something like normal, but it won't be normal pre-2020. And I hope it's not. I hope we have better, pick up one of Sharon's points, I hope we have better employment contract situations so that we don't have the people that are vulnerable. It's no surprise that the gig economy and the people working in hotels are the people who transmitted the virus. I hope that our employers are more accepting of us working at home and being able to work remotely. That will see some kick into the regional economy in Australia. So there should be a whole lot of changes happening that have happened because of COVID, but I think we'll be able to live in a way that, the COVID itself is not too problematic for us.
Yeah, I'd echo both Sharon and Tony's sentiments that firstly, we are pretty normal in Australia at the moment, and the rest of the world looks at us with considerable envy that we can move around and do what we do. So we have a great degree of normality, but it's not normal on the international scene, obviously. But I hope very much that we will look at COVID as a learning exercise, because I think there could possibly be much worse things coming down the pike. Quite frankly, before 2000, there were 2 coronaviruses circulating in humans, 2 common cold coronaviruses that we'd known about since the 1960s, when these viruses were first discovered and named. Since the year 2000, that 5 more came across into the human population. The original SARS, which burnt out, two more common cold ones, the Middle Eastern one, which kills 30% of people, and COVID-2. So there are now 6 human coronaviruses circulating. 2 before 2000, 6 now. So something has changed. What changed? Well, one suspicion, of course, is that the Chinese started to farm wild animals. And if they weren't protecting them from bats, that may have set up a transmission amplification cycle, because these viruses seem to go from bats to other mammals to us. We don't know the exact transmission for this one, but we do know it for the original SARS. And we know it for the Middle Eastern one, which goes from bats to camels to people. So that's one risk factor. But the other risk factor is large numbers of people that have changed since the year 2000, is large numbers of people, as China becomes more prosperous, large numbers of people flying out of countries where they have these live animal markets and live bird markets. And I think that may be a major risk factor. So I think what we should do is be prepared for the fact this may happen again. And what we should do is look at every aspect of this pandemic. Look at it from the economic aspect, the social aspect, the medical aspect, the scientific aspect, epidemiology, what implications it has for how we conduct air travel and how we conduct immediate response. We should shut down planes immediately flying out of any region that has this. Try and get that past the airline executives. So basically, we need a lot of rethinking. And we need to regard this as a global issue. And I hope personally, we don't go back to some of the normals we had before, because they were stupid.
Well, thank you very much for sharing all your thoughts. And on behalf of the audience, I'd really like to thank you, not only for your time this evening, but for all your hard work over the last 12, 18 months. I'm sure it's been hugely demanding, but we're very grateful for your work. So to all our panelists, thank you again. And to the audience, please consider joining us again on the 6th of May. We have another a webinar with Professor Kim Mulholland. So thank you all and have a good evening.
Thanks very much.
See ya.
Bye.
Bye-bye.
Bye.